Well, good morning, and thank you for attending this morning. I'm Bill Roberts. I'm from Minneapolis, Minnesota, and work with the University of Minnesota and the Twin Cities Marathon. My slides will be up here in a second. I'm honored to be here as a representative of the American College of Sports Medicine and privileged to speak at this meeting. This is my first time to speak at this meeting and my first time in Sweden. My tie to Sweden is interesting in that in 1902, my great-grandmother and grandmother immigrated from Sweden to the United States, took the Norwegian-American Railroad to Minneapolis, went further west where my grandmother met my grandfather, and 18 years later my mother was born. So I think I'm the first to come back to Sweden since 1902 from our family. So disclosures, I am on the Science Advisory Board for RaceSafe, which is a tracking app for marathons. Otherwise, I have no other disclosures. What I want to do today is look at the cardiovascular risks of collapse during the marathon, look at the triage and protocols for the medical side, and then talk a little bit about some of the cardiac complications from a little different perspective than covered in the last talk by Ellen. Marathon participation is rising, and from the mid-'70s through today, the number of participants in the marathon is approaching 2 million. So there's a lot of people on the roads at the marathon distance and even beyond. The basic differential for a person who collapses at the marathon includes what I call the 5 H's: the heart or cardiac arrest, heat stroke, exertional hyponatremia, hypoglycemia, and then the postural hypotension, which is probably the largest group that falls down. So looking at Twin Cities Marathon data, if you look at the causes for collapse, cardiac arrest is about 3 per 100,000, and postural hypotension is about 2,400 per 100,000. So on a scale, we have a cardiac arrest at the Twin Cities Marathon about every 10 years or so, and we have people fall down with hypotension almost every year. What we're going to focus on today is the cardiac events, and sudden cardiac arrest and cardiac death are really high visibility events when they occur in the public, and the marathon is a public event, and these arrests often overshadow the event and get sometimes very sensational media coverage, which can become a barrier to exercise. So my goal in marathon medicine is to have no matter what the outcome is, have the news story read, medical care was quickly on the scene. And I think if you can get that, then the outcome, and we sometimes can't control it, is some people are going to die from cardiac arrest when they collapse. And if you're going to collapse from cardiac arrest, probably you're better off at the marathon, as I think you'll see through this talk, than you are on a regular day in any city in the United States. In the mid-'70s, a cardiologist by the last name of Basler hypothesized that marathon running gave you immunity to atherosclerosis. And he claimed that not a single marathon runner had died due to coronary artery disease in the decade prior to his talk. This was presented at the New York Academy of Sciences meeting on the science and medicine of the marathon in 1976. He missed this paper from the 1973 marathon that was published a little earlier in the year, where a 44-year-old male had died following the Boston Marathon. In the next talk in the Academy of Sciences meeting, Tim Noakes, at a much younger age, who has never been one to shy away from controversy, gave a paper showing that at least 6 people had died during marathons and kind of debunked that hypothesis. Although the people from the press picked up on Basler, but they didn't really pick up on what Tim had said. He followed this with a couple other papers over the next few years. And in the mid-'90s, Barry Marin called me. He had recently moved from Washington, D.C. to Minneapolis, and he had the data from the Marine Corps Marathon and wanted to combine it with what we had at Twin Cities Marathon to look at the death rates in the marathon. And we combined that data and published our first paper that showed about 2 deaths per 100,000 finishers. We re-looked at that about a decade later, and across the entire database, the death rate had dropped to 1.1 per 100,000, but in the last decade, it was roughly 1 per 200,000 finishers, so about a quarter of what we had shown in the first paper. And we attributed this to the increase in the use and availability of the automatic external defibrillator, which are becoming more commonly used and more readily available by the mid-2000s. In 2012, there were 3 papers on the rate of sudden death in marathons. The first by Kim, published in the New England Journal, looked at the last decade, and I think it's important to look at the years here. This was the last decade of nearly 4 million finishers using internet and other means to look for sudden cardiac arrest and death. And he found about 1 in 100,000 finishers had a cardiac arrest, and about half of those died. Now, Webner, in the same year, looked at 1976 through 2009, and he polled medical directors around the world to get a number of arrests and deaths and a number of finishers, and similar numbers out of that group. And we took, in 2012, the same group we've been looking at from Marine Corps and Twin Cities, and looked from 1982 to 2012, which was when both groups had been looking at the split in men and women, and tried to look at the differences in men and women that were completing the marathon. And we got a little bit higher rates, and I attribute this, one, to being a broader number of years, and also that when you're working with the race, you pick up on the arrests that occur that never make the newspapers, and that does occur. So what we tried to look at was, what's the difference between men and women running and completing the marathon in terms of cardiac arrest? And for cardiac arrest, the relative risk is about 6 times higher for men compared to women, and about 3 times higher for sudden death. So Dan Tunstall-Bedeau out of London Marathon kept very close statistics for his marathon at the time that he was the director, and he looked at the numbers from 1981 for 2006, and really had very comparable numbers to what you saw in the previous studies. About 1 in 50,000 finishers die of cardiac arrest. Of the 14 that died, 11 had coronary artery disease, and 3 had hypertrophic cardiomyopathy, which is a little bit different than what we have seen in the Twin Cities Marine Corps database. Interestingly, the age groups for these 2 groups were about the same in terms of average age, at 49 for coronary artery disease and 47 for hypertrophic cardiomyopathy, where normally you'd see the hypertrophic cardiomyopathy in the athletes under age 35 or 30. So when you look at who's most affected, it's mostly males, and mostly males over age 40. So about 80% of the Twin Cities Marathon, Marine Corps Marathon database is over 40, and in the London database it was 81%. So again, older males, usually around over age 40. And if you, it's usually unexpected collapse. So these aren't people who have had a lot of warning signs, but they either have ignored their symptoms or they just have a soft plaque rupture. So if you look at the sudden death rate in males, just looking at men alone in Twin Cities and Marine Corps, the death rate is about 1 in 30,000 or 3.5 per 100,000 finishers. And that's updated through this past year's races. So who is it that dies? There was a lot of speculation early on when I was involved in the marathon medicine groups that it was first-time marathoners who were dying. But if you look at this slide, there were 2 first-timers who died, but the rest vary from having had 1 under their belts to as many as 38 marathons prior to their cardiac arrest. So it's not just inexperienced new marathoners who die during races. And where do the races occur, or arrests occur? Again, it's mostly near the finish line, and if you ask people, they'll say, "What's at the finish line?" But this is looking at Marine Corps, Twin Cities, London, and Chicago, and you can see that from start to finish there are cardiac arrests. Now, the mode is at the finish area, but it occurs all the way through. The median for this is mile 20. So you have to be prepared along the entire course for an arrest to occur. Now, where you collapse may make a difference. Here's one of the men who died at Twin Cities Marathon, and the red arrow shows where his collapse occurred, which was right here. And that happens to be one of the most inaccessible places on our course. Now, we still had a defibrillator to him within a few minutes, but and when you look at his post or his autopsy, he had extensive coronary artery disease. So it may not have made a difference, but same year at Marine Corps Marathon, this man who died collapsed at mile 17. Again, one of the more inaccessible places in the race, and again had response to him pretty quickly, but was in a tighter spot to get to for the marathon volunteers. Now, sometimes you're lucky. This man collapsed at Marine Corps, was running just in front of a cardiothoracic surgeon who responded within seconds, had his cell phone with him, called the ambulance, completely independent of the medical group, got him in the ambulance, went with him in the ambulance to the hospital that he works at, scrubbed in his running clothes, and bypassed the guy before the race even really got started. So sometimes where you collapse makes a difference. Similarly, this runner at Twin Cities Marathon had nearly finished. He collapsed at 3 hours and 30 minutes into the race. He was about 200 meters before the finish line, and he collapsed right in front of one of our ambulance rigs with one of our carts there, and they were on him in seconds. And he was resuscitated. He was bypassed before the last person finished the marathon. So sometimes timing is everything, and being in the right place at the right time helps. This is his tracing from the automatic defibrillator. So afterwards we interrogate the defibrillators to see what happened. And you can see that he had a shockable rhythm, and he was shocked here, and he didn't respond, and so they shocked him a second time. And then just to remind you how long sometimes it takes to get a recognizable rhythm after defibrillation, I put in a couple of the other panels here, and you can see that in the 7th panel of 12, he finally develops a rhythm that's recognizable to most of us. And one of the great things about an automatic defibrillator is at the rhythm the whole time waiting for this to occur. You continue with the CPR and follow the instructions of the defibrillator, and usually it works pretty well. There are some people who have a history consistent with angina prior to the arrest that I've been able to find in our database. And one of the runners who died at Twin Cities Marathon had presented to his physician 2 days prior to the race with epigastric discomfort. Angina, but at the time was interpreted as dyspepsia. And he died in 1989 at our race. But he had developed symptoms at 20 miles and kept running. So again, if you have symptoms, you really should stop. There was a runner in London who had symptoms of angina, reported to his physician and his family. He went to his physician. They did a stress test. The stress test was negative. This was done about 2 months prior to the marathon. And he died of a coronary artery disease at the marathon in London. We had a similar runner at Twin Cities Marathon who was 52 years old, had decided to get a stress test because he was 52. No real symptoms prior to this that would make you think he needed one. But he had a normal stress test 3 weeks prior to the marathon. And he ruptured his plaque in the LAD just, again, about 200 or 300 meters prior to the finish. We responded to him quickly. He also was bypassed emergently at the hospital next to our finish line, and he was bypassed before everybody finished the marathon also. So what about training for marathons? We really don't understand the training statistics. I know of one person training for the marathon who died 2 weeks prior to the marathon in 2006. And we only knew that because his wife called the marathon and said he had to cancel his number because he'd passed away. And so we sent him the finisher's marathon medal and the t-shirt also. But we really don't know what the training statistics are. And they're probably part of the statistics of people who collapse on the street and die. And if you collapse in the United States in a major metropolitan area in the city, your chances of leaving the hospital are between 5 and 10%. So in a city like St. Paul, where they have a really pretty extensive response system, it's about 10%. In some other cities, it's about 5%. So how do you recognize somebody who collapses from coronary artery disease or from a sudden cardiac arrest during a marathon? Well, the collapse is very sudden. And unlike postural hypertension, where you kind of swoon and catch yourself, these people go down hard and fast. There's no protective mechanism. There's no reaching out with the hands. There's no broken wrists. It's broken faces, abrasions, broken teeth, broken noses. And these pictures, as you can see, this is from the man who collapsed at the Marine Corps Marathon in front of the cardiac surgeon, and you can see the abrasions on his face. This is from one of the deaths at London Marathon from Dan Tunstall-Pideaux's database, showing the fractured nose and the abrasions that occur. So there's no sticking out of the hands. The last person who died who collapsed at Twin Cities Marathon that was actually saved went down so hard on his face that he fractured all the bones in his face. So the intubation was very difficult because the bones were floating and there was a lot of blood. So it can be a messy procedure to get these folks intubated. When you see someone post-race or who collapses during the race and they have seizure-like activity, that seizure-like activity shouldn't be confused with a seizure or neurologic problem, but it's often just the effects of the acute hypoxia on the brain. And it's a very brief seizure-like activity that occurs. And it's usually very early in the course, and it's usually very brief. And it precedes the time of loss of consciousness. Some people do have a few symptoms during the race, as I talked about in the last couple of slides, but if they stop, are smart enough to stop, the first thing we do with them now is we put the automatic defibrillator on them in case they do arrest while we're waiting for the ambulances to arrive. The treatment in the field is immediate CPR and trying to get the AED to them as quickly as possible. And if you get that AED on right away, and they're defibrillated, that's what's going to save them. So it's that time to defibrillation that makes the biggest difference. And with each passing minute, the chance of survival goes down by about 10%. So a lot of the strategy for cardiac arrest at the marathon is how can we get an AED to a person as quickly as possible? And how can we get as many people trained in CPR as possible? So at Twin Cities Marathon, Boston Marathon, Houston Marathon, Chicago Marathon, in the exposition that's associated with the marathon, we're teaching CPR to anybody who shows up. Likely the first person to respond to a downed runner is going to be another runner. So if we can teach all the runners CPR, we have a better chance of survival. And if we can teach all the families of the runners CPR, who may be along the course and may be the first to respond, we also increase the risk of survival, or the survival rate. So it's getting to the compression-only CPR, which is pretty easy to treat, and getting the defibrillator there as quickly as possible. And that's fairly simple at a soccer match or a baseball game where you have a very confined area. It's much more difficult on a marathon course or longer where the field of play is 26 or 30 miles, 42 or 100 kilometers. So the biggest part of the preparation is how do we get our external defibrillators to the runners as quickly as possible. And we use a combination of carts and bicycles. This is one of our bike team members. Bike team members who carries the AED on the back of the bike. And they ride along the course, and initially they're spread out on our course at 2-mile intervals. And as the race closes, they move up 2 miles at a time until the first of the 10 teams gets to the 25-mile mark. And then they start to close down to 1-mile intervals, and then they start coming in at half-mile intervals. So we try to have everybody in the marathon within a mile or less of a defibrillator at all times. In addition, we have golf carts or gators that have AEDs and full defibrillators on them, and we have advanced life support ambulances shadowing the race that can respond fairly quickly to these bike groups once they get there. The last 2 saves that we've had at Twin Cities Marathon, which on race day includes a 10-mile race and the marathon, have been AEDs applied by our bike teams. And that's our last 2 arrests at Twin Cities Marathon events. The other big part of the strategy for cardiac arrest is the communication teams. And we use a kind of an overlapping system of cell phones. So we have course marshals. So I can see the next course marshal and to either side of me. So if somebody goes down between us and each of us calls it in, we have the location pretty well triangulated for the ambulance responses. We have ham radio operators, and the ham radio operators are located at all of our aid stations and with our first aid stations also, so they can respond. If something happens, like at Boston when their bomb went off, all cell phone communication was stopped. So the ham operators and the shortwave radios that we have in backup act as our secondary form of communication. We've added the Race Safe app to as many of the volunteers that had iPhones, which this would work on. And if you have the iPhone on and respond to this, the GPS location comes up. So when you push the emergency button on this app, that goes to the ambulance service, they know exactly where you are. Now that's important in Minneapolis because there's 42nd and Minnehaha is 2 different intersections about a mile apart, depending on whether you're on Minnehaha Avenue or Minnehaha Parkway. So it's critical that the location be clear for the responding ambulances. The Race Safe app also pulls up the medical record of the runner, which is nice for those of us who are responding. The other part of the communication is the volunteer training them what to do in terms of response for runners who go down, knowing their exact location for the 911 calls, and teaching them to make sure that they give the runner's number. Because if 2 runners go down at once and an ambulance is responding to runner A, but runner B group sees the ambulance and flags them down, the ambulance gets hijacked. And then you don't have anybody responding to runner A who may be in more desperate straits. So we also try to make sure that our volunteers understand where they are and who they're calling for so that we get the ambulances to the right person at the right time. In 2006, Molenkamp from Germany gave this presentation at the American Heart Association meeting. He had looked at men over 50 who had finished at least 5 marathons in the past 5 years. And he'd show that there were pretty high coronary artery calcium counts. And 2006 was the 25th running of the Twin Cities Marathon. And I thought, we have a group of 80 people who have finished every marathon. So we can do this at Twin Cities. So I got together a group of people and we contacted all the finishers from all the races at Twin Cities who had done at least 1 marathon a year for 25 years to look at their coronary artery calcium counts. And this is the publication that came from this. It was published last year in in the Missouri Medicine Journal. And part of the group became part of the is part of this group that is really kind of sensationalizing the risks of endurance activity. And this is sort of a complement part of what was said in the last talk. And this isn't the cover that I would have used. I would have put a question mark here, and I would have emphasized that this was coronary artery plaque volume and not just straight counts that occurred in this group of runners. So when you look at this data and lesion prevalence, there was really no difference in the number of lesions between the sedentary and the marathon group. So there's no significance in the prevalence of the lesion, no significant difference in the p-values in those groups. The total plaque volume was higher, but we're not really sure what that means. I can tell you that all 50 men in this study group are all still alive and kicking, and most of them are still running marathons. So we're at 35 years out now, and that group is still fine, as best I know. Where it comes out is in this demographic data and the differences, and I kind of tried to make it a little bit more easy to read. So I pulled out some of the characteristics that I thought were important, and there were a tremendous number of smokers in this group of marathon runners. Over half of them had been smokers or were currently still smokers in that group with the high counts. And their typical marathon group, their BMIs were low compared to the sedentary group, but the sedentary group was actually in the obese range. And this group is on the near overweight group. Their blood pressures were better, their lipids were a bit better. There were no diabetics in the marathon group or there were in this control group. But what's missing that we had looked at it and didn't publish, which I think was unfortunate, is the family history and the diet. And the message I would send from this is that really you can't get away from the sins of your past. So some of these people in this group started running marathons when they were 18, but many of them started running when they were in their 40s, when they figured out that what they'd done in their 20s and 30s probably wasn't such a good idea. And that may be part of what we're seeing here. But we're not seeing these people drop dead from their participation in marathons over a number of years. So in summary, sudden cardiac arrest does occur in marathon runners. It's relatively rare. Probably more rare than cardiac arrest in the general population on a daily basis. Mostly it occurs in men who are over age 40 who have coronary artery disease that's silent. It's often comes unexpectedly. That is, they have lesions that aren't large enough to cause symptoms, but they're large enough that when they rupture, they cause problems. They really are at much less risk than their sedentary counterparts. And so I wouldn't consider the data from the first talk or what I've shown with the coronary artery study from our group to be a reason not to run marathons. The arrests do occur from start to finish. So you have to be prepared for arrests along the entire course. But you really have to be prepared in that last half mile or last kilometer through the finish area, so past the finish line, because that's where most of them are going to occur. And it's just not just first-time marathoners, but many veteran marathoners who have their coronary artery event during the marathon. Now, sudden cardiac death can be reduced. It can be reduced with early defibrillation and CPR for those who do arrest, but that doesn't ensure survival. So some are going to die who do arrest. And if you're involved with marathons on the medical side and you've been through these events, you are a little used to it. But what to remember is that the people that aren't medical who are helping with these events are often very hard hit by this. And it's good to have some kind of counseling sessions for those folks who are involved, who aren't medical, who aren't medically trained, and who aren't used to working with death during activity. Sudden cardiac arrest survival to me seems more likely if you arrest near the finish, where most people have most of their assets. But you can survive arrest across the entire course if things are set up for that. And it's best if you're going to arrest near somebody with an automatic defibrillator who can respond very quickly. You really have to spend some time in education with your volunteers and your runners to know how to work the protocols and use the equipment so that you take advantage of what you set up to intervene for cardiac arrest. And that includes education for volunteers and for the runners, so that everyone knows there's risk and everyone's prepared to respond. Now, the screening for cardiac arrest, I think, is difficult to do. The false positive rate for EKG and for the exercise stress testing is pretty high, so you don't really have a good guess of what's going on with just those screening tests. And the false negative rate is also very high for those tests, if they're, especially in runners, if they're not done to maximum or really done to exhaustion, but using the standard cutoffs that the cardiologists like to use for stress testing. Now, there's a paper coming out this summer in British Journal of Sport Medicine outlining a screening technique or procedure that they're using in South Africa that I think has some potential, that uses a screening protocol during the registration for the marathon. And what they do is ask key questions regarding family history and symptoms to see if any of their entrants have symptoms that or history that might lead them toward a cardiac arrest during the marathon. And when those questions are answered yes, they start to get emails from the race organization suggesting that they visit with their doctor, suggesting that they look at their risk prior to running the race. And they're doing the same thing with illness in the week or two prior to the race with email. So some of the technology that we have may improve our ability to do some risk stratification and risk screening to reduce the risk during the race for some of our participants. And it'll be interesting to see how that follows through. I'd like to try some of that with Twin Cities Marathon in the future. I'd like to just take a moment to recognize Dan Tunstall-Pideaux, a good friend of mine, and who was the medical director of London Marathon from its first race through 2006. And he passed away this past winter. He'll be missed. He was a person who actually spent time looking at the science behind what we're doing in the marathon, and I think one of the fathers of marathon medicine. So with that, I'll end and thank you for having me, and thank you for your attention. I think we'll have questions and answers now.
So now this is open for questions, and we already have a first question here. Do we have a mic?
Thank you very much. Thank you very much, Professor Roberts. Fascinating presentation. I'm wondering if you would like to comment on the value of the pre-participation ECG in the prevention of the sudden cardiac arrest, because it seems there is a controversy on this issue. Europeans have a different cardiologists. European cardiologists have a different opinion of that than Americans.
So the question regarding ECG screening, at the marathon level for regular community level recreational runners, I'm not sure that it has much bearing or would be very useful. The chances of picking up ischemia for coronary artery disease with an EKG and a non-acute sort of screening event is pretty slim. And the issue of pre-participation screening for young athletes and the differences between the European model and the U.S. model. My biggest concern with that is the false positives. The EKG has a fairly high false positive rate, somewhere between 2 and 10%, in 2 probably to 5% in pretty good hands, and could be as high in the U.S. in average hands as 30% for athletes. Some of the newer criteria coming out of the Seattle conference can bring that false positive rate down. But when you apply a false positive rate of 2% to a very low incidence occurrence like sudden cardiac death of any cause in an athlete, which is probably somewhere in the range of 1 in 40 to 1 in 200,000, the false positives really start to overshadow and probably start to do harm from my perspective. So I think a lot of the feeling from the American Heart Association, the American College of Cardiology, is that the false positives outweigh the benefit for doing the screening. In Minnesota, where I'm from, we have pretty close monitoring of the high school athletes. So the high school athletes in Minnesota vary in age from 12 to some are as old as 19, but mostly they're 15 to 18-year-old kids who are participating in sport. And we have about 100,000 unduplicated athletes each year. And from 1992 to 2010 or 11, there were 4 deaths that were recorded during activity or within the hour of activity following high school sports. So that is, I forget how many million, about 100,000 times 20, so 2 million people. So 4 deaths in 2 million is pretty hard to prevent with an EKG screening program. So we don't think that it would help us very much. We do try to use the pre-participation screening exam that we do, which includes a questionnaire and physical exam, to narrow down people with risk, so people with positive responses who on closer questioning appear to have more risk. We'll do the EKG and additional workup. So I think it kind of depends on how you want to spend your healthcare dollar. If you want to spend your healthcare dollar on screening for something that could cause a lot of false positives and generate a huge number of additional medical tests, that's one way to do it. If you want to try to narrow down the screening with history and physical like we're doing in the States, and try then to use the EKG as a case-finding tool to look more specifically at a higher risk group, that's the approach that we're using currently in the United States. There are some people in the US who are doing routine EKGs. We're trying to set up a study to look at not what you can find with an EKG, because we know you can find things, but what's the outcome of a group that's screened with EKG versus the outcome of a group that's not screened with EKG, to see if there's actually differences over a period of a decade or so in those groups and people who are screened with EKG. So in the US, we're using the EKG as a diagnostic case-finding tool and not as a screening tool. My personal opinion is that it's not a good screening tool for sudden cardiac death in young, healthy athletes. Does that cover?
Are there other questions? Over there.
Roland Nebel from Germany. Nice talks. Thank you very much. I have a practical question. I'm working as a cardiologist in rehab, and I've recently had a survivor of a triathlon full distance Ironman, and he collapsed within the changing zone and survived. No structural heart damage, no coronary artery disease. How do you deal with these patients? I mean, I don't expect a perfect answer because there's no evidence-based medicine about this. What I do, I tell you at once, I invite the spouse as well, and if I don't see any changes, especially in the MRT, I encourage them to go on, even with the full distance, because it's part of their life. Would you agree?
Boy, that's a hard question to answer. You know, when somebody's had an arrest and you can't find the reason, it's hard to make good recommendations because you're really shooting in the dark. Or in my case, shooting in the light because I have a poor aim. But you don't have a reason. It's really hard to give a recommendation. I'll tell you that many of the runners who had cardiac arrest and survived at Twin Cities Marathon are back to running and are running marathons again. Is that a good idea? I don't know. But in that group of undetermined cardiac arrest, so the folks that arrest, that you revive, who survive, and then you can't find a reason, they're probably similar to the people who die, and they go through an autopsy, and you can't find a reason. And it's probably an arrhythmia for something that we can't find. So if you've been able to do the studies to rule out abnormal coronary artery distribution or development, and you've been able to look at the rhythms under stress and not been able to find an abnormal rhythm, and they have a normal EKG, I guess I would probably tell them that the chances of this happening again are still there, and probably they're higher than they are in the average population, and they could die doing it. But you know, if that's their life, it's hard to take that away. So I would probably give the same general recommendation.
Because one of the most important topics in both of your talks was that it could happen right from the start on. Because if you would take this into account, we would even hinder them from running a mile or even less. Mm-hmm. And that's not part of their life then.
Yeah, so what to do? I think, you know, what to do with people who've been disqualified is another thing. You know, what do you tell them? So if you want to tell this guy that he can do it, but, you know, maybe he'd be safer picking a lower intensity, less duration activity, that might be another option. The lucky thing for him is that he collapsed during the triathlon where everybody was prepared for this to happen, and he collapsed in the transition zone where there are a lot of personnel and very quick response times.
Other questions? We have two in front.
Jose Calvet, thank you very much for your presentation. So from your graph about where the deaths occur, it seems that close to the end there are more deaths. So then I wonder if this is related to the intensity of the run when the runners know that they are arriving. So do you think that the intensity is a factor to have into account? And this question is coming also in the context of the high intensity exercise that is commonly advised and preconized by some people, even in people with no previous background of exercise training.
So the question is, do I think the mode of sudden cardiac arrest near the finish area has to do with the intensity of the finish? And that would be my best guess. That is, as you see the finish approaching, you know, that excitement that occurs, it's almost like the fight or flight response that you get, which is an adrenergic burst, probably occurs. And so the natural response to pick up the pace and try to do better probably occurs in that last part. You know, my fastest marathon is 1 hour, 23 minutes and 2 seconds, but that's on inline skates. So a much different kind of marathon. It's much faster. It's much easier. And I do that because there's no bed and breakfasts on the marathon course, and it would probably take a couple in 25 miles. But that's what skates and bikes are for going those kinds of distances. So, but I know that when I get within sight of that finish line, I get excited and I push a little harder. And I think probably everybody does that. One of the recommendations, that really isn't evidence-based, but is not to really get so excited at the finish, to maybe reduce your risk. I don't know how you do that. I mean, most of us who are athletic, who have been competitive, know what it's like to compete, and that adrenergic surge may be part of it. It's also interesting to me that people collapse along the entire course. Why 100 meters into the marathon would you collapse with cardiac arrest when you've done 3 20-milers within a month before? What's the difference? Again, probably the excitement of the race, or bad timing, or in this case, good timing because you did it during the marathon and not on one of your training runs. So why does it occur more there? It may also be that everybody makes it to the finish, pretty much. And so that's where, statistically, you may just have a better chance. If you look at Kim's paper from New England Journal, 47% of the arrests that occurred were within that last, from the 26-mile mark through the finish line. That's a combined number for half marathon and full marathon. But again, quite a big part of them. But what I was trying to emphasize is that it can occur anywhere on the race course, and you have to be prepared from start to finish.
What about intensity, the high intensity training for people that are not having a background of exercise training?
Many of even the sort of what I call citizen runners do high intensity training. They're trying to improve a PR. They're trying to qualify for Boston or some other race, and doing high intensity training. And I'm not sure why they don't collapse during that high intensity training like they do during the race itself. And I think part of it is just the race itself has different conditions for the body and stimulates different hormones and gives you more risk.
Thank you. Flemming Dehler from Copenhagen. It's a question or a remark to Ellen Dawson. When you talked about the troponin T elevations, the acute elevations, you almost alluded to it as this was a clinical problem. And I don't really agree with that, because, I mean, if you see an isolated troponin T, you wouldn't react on that. So I would just tone that down a little bit. The other thing I would like to ask you is your quite impressive pressure volume curves, non-invasively measured. Have they been validated with an invasive technique?
No. Yeah, I agree with the clinical side of things. I think that was the point I was trying to make, that it's not clinical, and that clinicians should be aware that it's not clinical, it's just a physiological response. For the pressure volume loops, Rachel, are they looking to validate that in Nijmegen? Yeah, so that's the next step. They are going to try and do some work with Dick Tyson in Nijmegen to see how well they match to a pressure volume loop. Because obviously it's not a pressure volume loop per se, but if we have an index, a non-invasive one, it would be marvelous, because we are looking then at the full cardiac cycle, the full contraction and relaxation. So that's the next step. Yeah, they are hoping to validate it.
Yeah, I would just comment on the troponin. I had started doing this in 1982 when the CKMB was just coming out, and it was the same problem then. The marathon runner would present at the emergency room with an elevated CKMB, but really not have the rest of the clinical picture to go with myocardial infarction. And I think both troponin and CKMB you have to put into the full clinical picture, just like Ellen said, to make the diagnosis. And I think one of the messages out of this is that for the clinicians who are taking care of the runners post-event, they have to be aware that these enzymes can be elevated and not be a part of an acute coronary syndrome. So that's the big message there, and that it isn't just a one-time elevation, but has the biphasic or bimodal peaks that you have to be aware of if you're following them clinically. So people can arrest. In my experience, most of the time it's a catastrophic arrest. And they usually end up with surgical procedures. But you can arrest and survive, and have the usual clinical course. But you can end up with another kind of collapse, heat stroke, or just a postural heat collapse and end up in the ER and then suddenly be pushed into the acute coronary pathway if you don't pay attention to what Ellen has shown in her talk today.
Any more questions? If there aren't any, then I want to ask you to applaud with me for the speakers, and I all thank you for coming to this session.